Okay, that's being done.
Okay, good.
Send a bit of that. That's
All
still
right.
showing. All right, looks like we're going good.
Yeah,
Cool.
everybody in online land can hear us.
Yep. Yeah, I checked that beforehand. So
Oh, that's awesome. Great. Well, good evening, everybody. Yeah, it's so good that you guys could come. I really appreciate your support. And I'm just really as proud and glad to see this as you are to be here, hopefully. So, without further ado, we'll dive into the subject for tonight. Something we've never seen ever before. I'm sure none of you have ever seen any seizures, right? Yeah. It's an oddball, and it's a diagnosis that sometimes can fool you because sometimes syncope or fainting can look like a seizure, and seizures can look like a faint. So there's some cues along the way they'll give you to distinguish the two, because they're obviously treated a little bit different in the field. Sometimes it's really tough to tell the difference between the two, and sometimes the altered mental status patient or the agitated patient may be a seizure patient, or a seizure patient may be due to something else. So as you can tell by the introduction here, there's a lot of overlap. Isn't that the way the human body is? You know, and you know as well as I do, our patients do not read the textbook. So everything we learn in school and in your training and stuff is off the chart sometimes, and we have to play around. So, and just as a fun side note, remember in school we were always taught I before E except after C. That violates the English rule anyway. I can't remember where the word seizure came from. So,
don't mind me.
ready to advance.
Just readjusting so everybody can actually see you.
Yeah. All right. So seizures affect what? Excuse me. What organ system of the body do seizures affect? Cardiovascular. What do you think? Yeah, pretty much the central nervous system, right? And the chief organ of the central nervous system, of course, is the brain. The brain needs absolutely two things to survive, two food groups. It needs oxygen and glucose. Oxygen and glucose, very important. Why? Because you, out in the field to begin with, when you see these patients, what two things can you interface with right away? Oxygen and glucose, right? And one of the first things we do in an unresponsive or altered mental patient, we check the glucose. We do that at bedside too when they hit the ER. So, ready when you are, Tony. So this is just interesting facts. And by the way, I have to give credit to power, what's it called, slideshare.com. I borrowed the slide sets from them because I thought they were really good. And Lazy Dan or Busy Dan, either one, didn't get to making my own slides. I like to make my own. So anyway, the human brain is only 3 pounds in the average adult. Pretty remarkable when you think about it. And it actually is a little bit bigger in children in relationship to their body than it is in the adult. That becomes important in trauma cases. Maybe we can do a trauma thing later on. So for only 3 pounds, this puppy soaks up a lot of cardiac output. You know, 30% of the cardiac output is for or used by the brain. Think about it. Something to keep in mind, you guys, when we're dealing with cardiac patients, respiratory patients, metabolic derangement patients, where they're losing their cardiac output, and the brain is not getting the oxygen it needs. Another reason why oxygen for your altered patients is not a bad thing. Sometimes healthcare providers, when you guys hit the door, I'm sure you know, they may look at you odd or criticize you for putting oxygen on a patient that's a little altered. It's kind of unusual, but it may happen. And you can tell them, well, I'm protecting the brain a little bit. The brain needs the oxygen. So I won't quiz any of you as to what cardiac output is, right? I'll just tell you because all of you will be able to tell me it's stroke volume times, remember? So it's stroke volume times actually the blood pressure. That's what cardiac output is. The brain can't wait. The brain is very selfish. It typically can't wait. As you know, when the heart stops, you have 4 to 6 minutes before you start getting brain death. Same thing here. When there's a seizure going on, there's minutes before the neurons start feeling it. And the brain hates it when it loses oxygen or sugar. The other two things to keep in mind, these aren't foods like oxygen and sugar, but they're very, very important. If the blood flow is compromised to the brain, bad things happen, right? If the blood flow is compromised, we see a patient suddenly droop to the left side. That's called a stroke. If brain flow is compromised, they can seize. If brain flow is compromised, they can get really whippy, altered, and so forth. So these are 4 things that the brain cannot wait for. Go ahead, Tom. So we have a short fuse on the brain. Next slide. We get really irritated and annoyed. I know a lot of us in the room, if we don't get our caffeine in the morning, we get a little annoyed too. That's the energy part of that slide. So seizures are, seizure is like saying the word crayon. If I say crayon, everybody in the room is thinking of a different color, because crayons come in different colors and they come in different lengths. Sometimes they're the small Crayola crayons, sometimes they're the big crayons, or the big fat ones, and your children or grandchildren can have fun with coloring. And of course, they color on the walls and on their bedposts. So we're going to go through some different definitions for you so you can kind of get it in your head that seizures do come in different colors and different varieties. Bottom line question for you, do we treat different seizures in different ways in the field? No. Right. So that's nice, isn't it? You don't have to remember or memorize a litany of different treatments for different seizures, which is heavenly. That means a lot for you guys in the field when you're trying to think of 50,000 things at once. So for us in the emergency department, it does become an issue, whether it's a complex or a partial or a focal or a gigantic seizure. But with that in mind, there is a caveat. Often we'll start every seizure patient pretty much on the same pathway, and then later on it becomes important. Okay, so let's do some anatomy. The brain is largely 3 big parts. The first part and the biggest part of the brain is the cerebral cortex. That's the front of the brain that goes from here and around. If you're like I am, some days I don't have as much cerebral cortex as other days, so I'm a little whiffy around the edges. But this is the higher functioning part of our brain that helps us think, reason, has more short-term than long-term memory. This is the part of the brain that helps you function quickly, makes you think on the fast one. There is some papers that are some papers out there that list just thinking as a system 1 or a system 2. System 1 thinking is right up here in the front, and that's the quick thinking that we all do every day when we're working. You get called to a scene, your call is unresponsive, possible seizure. So already your brain is starting to think, what am I looking for? What kind of vital signs do I need? Do I need to do a finger stick? Do I need to do a 12 lead? What's the patient going to look like? What medicine do I want to use, and so forth? That's your system 1 thinking. System 2 thinking is like if you're taking a test and your next question is an essay question. And so it's going to take you a good 10 minutes to think it through, to process your thought, and to write down your thoughts. That's system 2 thinking. It takes a little bit more time. Okay? Next slide. So that's the cerebral cortex. And you have short-term memory and instant thinking and longer thinking back here. This is the cerebellum, located in the back of the brain. That's responsible for balance and coordination. So some patients, when they have strokes or seizures, it may present just as an imbalance. They may look drunk or intoxicated. Why is that important? Anybody know? You get called to an intoxicated patient. It may not always be alcohol. It may not be a drug they're on. It may be a seizure. Okay? The other big part of the brain that we have the cerebrum, the cerebellum. This is also called the medulla, or the medulla. It's most of the time we pronounce it medulla. It's down below. This is where the pituitary gland sits in the hippocampus. This is the emotional centers of the brain. The pituitary gland is the commanding endocrine gland of the body, so it dictates everything. So that I'm telling you that so you know how important it is when something happens in the brainstem. Down here, this is vegetative functions. This keeps our heart beating, our respiratory rate going. It controls vasomotor tone. It controls the flow through the kidneys, et cetera, et cetera. This is all the stuff we don't have to think about, which is really cool. Why people in a coma can maintain heartbeat, blood pressure, and respiratory rate is because this portion of the brain is unaffected with the coma. It depends on what's causing it. Okay? So seizures in the brainstem almost always cause sudden jerking movement. And the sudden jerking movement that we call, do you remember the name, medical term of that?
The Rigers or myoclonic?
Myoclonic jerking. Rigers is, that
The fever.
that fever shaking, yeah. And Rigers looks like clonus because all the muscles are shaking. The reason they're doing that is they're trying to reset the thermostat, trying to warm up. So if there's a lot of muscle activity, it should raise the core temperature. Doesn't always work. Yeah, that's how it works. So Rigers is just that shaking associated with the fever. Temperature's going up or going down. But myoclonic jerking is rhythmic or arrhythmic, jerking. Let's see. It's not the tremor. Tremor is steady and rhythmic. Myoclonic is a sudden jerk. It's just a little bit different. And you've all seen patients with Parkinson's disease, and they've got that little tremor. Okay.
Myoclonus is usually a sign of hypoxia, correct? As
Yes.
opposed to other things.
That's right. Yeah. So that's something to really think about is if they do have myoclonic jerking, they might be oxygen deprived. And most of the time, not all of them, seizure patients are hypoxic. Why? Because when you're seizing, the last thing your body's really thinking about is breathing, because the entire central nervous system is contracting and you're getting like thousands of volts across the brain. And we'll go into that in just a sec, whereby all the muscles are jerking, so breathing becomes difficult. Ventilation is difficult, so patients don't breathe. Okay? Any area of the brain can be affected with seizures. That's the cerebrum, the cerebellum, or the medulla. This is just a little bit more of a cartoon of what you're learning as a brain. This is where the cerebral spinal fluid is manufactured and lives, and then it goes down the spinal column. So when we do a lumbar tap, we're tapping fluid off the brain. Patients with hydrocephalus have more fluid in their brain. They are more prone to seizures. Patients with cognitive decline are more prone to seizures. Patients with dementia are more prone to seizures because the brain is shrunken a little bit. And I can go on and on. Think about it in a nutshell. Any disease or illness that can affect the central nervous system can increase the risk to seizure. Okay? So that can be as simple as the flu, because it's a viral illness that raises the temperature and can affect the brain, or it can be something really weird like, tertiary Lyme's disease. Okay? Yeah, next up. Okay. So seizures come about in any area, in any insult. Next slide. What causes seizure? Besides just plain old, I have a seizure before I've been an epileptic seizure. And that's not true. Fortunately, knock on wood, we'll have seizures. Hypoxia, big one. Can we do something about that? Answer simple. Yeah. See, I'm not giving you guys hard questions. Right. How much oxygen do they need? Do you know? What one device do we use on the finger so we know how much we're doing? Pulse ox, right. And the other side of that coin is the end-tidal CO2, right? How well are they ventilating? Are they getting enough oxygen and are they ventilating? That's very important. That's ABCs, right? I probably preach this too much when I teach EMS, but every patient, every time is always ABCDE, right? Whether it's a trauma patient, a medical patient, car accident, whatever. Always airways first, airway. And you say, well, Dan, that's kind of stupid. But how many of us have been in a hot moment and you overlook the airway? It's easy to do, right? Then you've done that. Patient seizing, and I'm not paying attention to that. They're really cyanotic. Do you want to do something about that blue color? No, because blue is my favorite color. Just kidding. Hypo and hyperglycemia. Can a diabetic that's in ketoacidosis with a sugar of 1250 have a seizure? I've seen it happen. The answer is yes. Can a patient with a sugar of 35 have? Right. Now, the 35 one's a lot easier to treat in the field than the 1250 one. Again, you give them fluids, but you guys will be giving them some dextrose in the field for sure. So that's another one of 101 reasons why a finger stick glucose is a good idea. And in the charts we'll review in the second hour, for sure, I kudos to the medics and the EMTs that did the assessments. They did finger sticks on these patients. Much appreciated. Hypoperfusion. Can you just shout out some things that would cause you to be underperfused? The brain's not getting the blood flow.
Sure. Yeah.
Yep, that's right. An MI, ACS, unstable angina, dysrhythmia, right?
Shock in general.
Yep, shock. So any sort of shock, good time. Whether it's distributive shock from sepsis, whether it's hypovolemic shock from your car accident victim that has an open femur fracture, anything that compromises the amount of blood flow through the brain will cause seizures or can cause seizures. How about drugs? Drugs can cause seizures, right? We see this a lot in overdoses, toxic drugs. I can't remember now what the drug was. Patient overdose unintentionally, it was an accidental overdose and they had a seizure. Electrolyte and chemical imbalances can cause seizures. A very famous electrolyte that can cause seizures in patients is a little thing that we like to put on our potato chips and pretzels and on your sausages in the morning, a little sodium maybe. If patients are seizing, one of the things to think about, you guys, is hyponatremia, right? So are you going to know that in the field? Are you going to detect that in the back of the ambulance? Very unlikely. If you are in advanced paramedicine and you're flying, for example, or you're in an advanced critical care unit, you may have an iStat machine that will give you electrolytes, or you can do a blood gas, and on both of those, you'll get a sodium. Sodium, you remember from class, you remember what sodium normal is? I shouldn't pick on you, but what is it? Potassium. Yeah, potassium is 3.5 to 5 usually. Sodium is around 135, give or take. Yeah. 130 is low normal. You get below 130, you start getting worried. So, different labs are different ways. But yeah, if the patient comes in and their sodium's only 120, there's a really good chance. Chemical imbalance would be hypo or hyperkalemia, hypercalcemia, hypocalcemia. So bottom line, any electrolyte disturbance can lead to seizures. Doesn't always. Fever we've already touched on. Trauma, of course, if someone whaps their head, or if they have an ICH, or they're bleeding out, for example, they can have seizures too. Yeah. How about this pressure? Actually, they should have put blood pressure here. Anybody can tell me what the difference is between a hypertensive urgency and a hypertensive emergency? I'm going to make you all doctors, but that way, one of you can work for me tomorrow. So let me shed some light. I hope you guys don't mind. Sometimes I divert it. The more education, the better you do. So hypertensive urgency is where your blood pressure is high, but you may not necessarily have any major organ symptoms. You may have a headache and may not feel good, feel fatigued. We all get these calls. Grandma's worried because her blood pressure is 178 over 94. But does she have any visual changes? No. She feels tired. Do you have a whopping headache? No. Do you have chest pain? No. Short of breath? No. Are you making urine? Yeah. So she's a hypertensive urgency. This is a blood pressure that doesn't need immediate intervention with nitroglycerin, a beta blocker, a calcium channel blocker. She basically needs a pat on the shoulder, a reassuring EKG, and some labs, and we're going to adjust your medication that you're already on, okay? A hypertensive emergency, on the other hand, is a presentation maybe of a seizure with a blood pressure of 210 over 100. It's a stroke with elevated blood pressure. It's a heart attack, an MI, a dysrhythmia, an end organ thing that's really compromising the patient and getting them in trouble. Another area is a pregnant female who is actively seizing, perhaps more towards the end of her pregnancy in the third trimester. She's having a eclamptic seizure. Now, here is the only difference between seizures over here and eclamptic seizures. Eclamptic seizures are treated with, that's right, mag sulfate. So when you guys have a pregnant female that's seizing, the first drug I want you to think about and reach for would be magnesium. Give her 2 to 4 grams IV. Dan, can I push magnesium fairly quickly? Yes, you can. It's in the usual scenarios, it's not recommended. We usually infuse it over 30 to 60 minutes. But you can push magnesium, you know, just a good slow push over maybe 2 to 3 minutes if they're actively seizing. So it gives you an idea, excuse me, of causes of seizures. So in a nutshell then, like I said before, anything that irritates this selfish organ up here, because this selfish organ is the command center of everything we think, everything we do, and everything we don't even think about, heart rate and blood pressure and so forth. So anything that irritates this and annoys this can cause seizure. So Dan, is my differential diagnosis list very long for seizures? Yes, unfortunately it is. And that's just the way the cookie crumbles. And I'm kind of a twisted fellow, I guess. I like medicine and well, I love it actually. My wife will confess to that. When are you ever home? But when we do medicine, the reason I think, and hopefully in all of us, that we like it is because of the challenge it gives us. You know, granted, some days are routine, boring, and you don't go to work like, yeah, you go to work like this. But when we start to be detectives and Sherlock Holmes and start to divide it out and to really think the cases and then get the follow-up, it's a lot of time. All right, how do seizures happen and what parts of seizures are there? There's 2 things that go on when a patient has a seizure. One, they have a biological event. Something triggered this, the fever, the hypokalemia, the hyponatremia, the trauma, the pregnancy, whatever it is. Something triggered a biological discharge in the brain. The brain got angry and it's electrifying, like, yeah, it's electrifying. It sounds like John Travolta. So that's what happens in the brain. And then what we see is this. So we don't see the biological event. We see the results of the biological event, right? You got me? So that's why it's so difficult sometimes to sort out what's causing the seizure. Because we don't know. You know, when you go to the scene, are you going to know what their sodium is? You could probably know if they're, 9 months pregnant. There's a lot that we can't find out until later on. So that's the critical change. Now, how long between this and this? Can it be seconds? Can it be minutes? Or maybe even hours? Yep. And the answer is all of the above. So if I gave you a multiple choice test, it would be D, all of the above. Thanks, Don. So neurons don't like what's going on. They're not getting oxygen. They're not getting glucose. They're not getting perfused right. Something goes on. The neurons just fire away because they're irritated and annoyed, kind of like the children in kindergarten that are told there's no recess today. Or like adults that are told you can't go on vacation. Get really angry. So we discharge. And as a result, the body begins to show us a seizure. Seizures come in all kinds of different colors, and I'll get into that in a minute. And the biological event is electrical conduction. So seizures are an electrical discharge. What other organ likes to fire off an electrical discharge? The good old ticker, right? And so what we do for the heart sometimes is to fire electricity at it to disrupt it, to kind of short circuit the heart. I would not suggest that you use the light packs to do that to the brain. I will have to pull your certificate. I'm sorry, but you can't.
We really want to sometimes.
Now, there are patients out there, and this just stays in the room. There are patients out there that we would just love to put the paddles to the head. I think it would help them part of this. All right, you didn't hear me say that. So, biologically, this is fun too. Is this something that EMTs and medics really have to know? Sort of, but you don't have to know it. I mean, I won't be, when I resign your certification, I will be testing you on, catecholamines and all this. But when we do pathophys in school, right, Casey? We talk about this, right? So all of you just go back to pathophys when you did your training, and you'll know that there's a huge release of catecholamines in the body. And the catecholamine that we carry on the ambulances, we know as epinephrine, right? Or adrenaline. Huge release. This sometimes is up to 5 to 10 times normal. So you can imagine the discharge on the body. Why are seizure patients tachycardic? Why are they hypertensive? There you go. Why are they sweating? It's catecholamine. So it's fight and flight. That's your that's catecholamine. The body requires 250 times more energy when you're going through a seizure. So that's why patients in the post-ictal period and after a seizure are white. I mean, absolutely exhausted because they've exhausted all their energy stores. So why is it important for us in the hospital to give them IV fluid and maybe some nourishment? Some of these patients are so bad they need TPN, total parental nutrition. Wow, look at this. You wouldn't think this would happen, right? But our blood flow increases by 250% during a seizure. And Dan, didn't you say a little bit ago that hypoperfusion could be a cause? Yes, and that's the exception. So if the brain is being hyperperfused because of trauma and their hemoglobin is only down to 6 and they've lost like 5 units of blood, you won't see that kind of cerebral flow. But you will see it in a patient that's maybe seizing because of their epilepsy. Okay? And the consumption of oxygen goes way high. So the brain is actively discharging and the brain is working triple time and it needs substrate. It needs oxygen and glucose. All right, next slide. So this is all going on. This was on the previous slide. For I think in our region, I think only Templeton's doing lactate on board, right? Yeah, and they're doing a grant or whatever. Rarely do you do lactates in the field, but down the road, eventually, whenever Massachusetts wakes up to reality, and again, I would say that, we'll be doing lactates, and lactates are very important to rule in and rule out a septic patient. Look at this, you guys. Lactate goes up 20%. Why do you think that is? Yeah, muscles. That's right. So the muscles are jerking and jerking and jerking and moving around, or the patient's thrashing about. Can you imagine how much energy that's using? And the cells are constantly contracting. So what happens to the oxygen supply with the muscles going back and forth, over and over and over? There's only a limited supply of oxygen there, right? Once it gets depleted, the body goes to anaerobic metabolism, and whang bang, it produces lactic acid. Patients get even worse because with lactic acidosis, they become acidotic. Do they breathe right? Nope. They begin to hyperventilate to correct the acidosis. One thing leads to another. Kidneys shut down. They go into ATN. That causes cardiac dysrhythmias. Yeah. See how one thing leads to the other. Necrosis of the brain can take place, but that's not an immediate worry in the field. It is a worry if you get called to the scene and Uncle John has been seizing. Well, how long has he been like that? For 40 minutes. Well, why didn't you call us earlier? That's a serious problem. If the patient's been seizing for over 30 minutes, that's status epilepticus. You're in trouble. So next slide. Oh, by the way, Dan, do I need an airway in these patients? What do you think? How would you assess an airway with a brain problem? What brain tool do we use to assess whether a patient's alert or not? Good old AVPU or your GCS, right? So if a GCS and you're seizing patient and you do a GCS, let's say that I'll make it real easy. Your GCS is 3. Do they need an airway? Yes, they certainly do. If they've got a GCS of 14, their eyes are closed and they're seizing, but Mary, do you know where you are? Yeah, I'm having a seizure. Can't you see it? Yeah, it's like you all know what kind of seizure that is, right? Yeah. No, you can't. So seizures don't affect consciousness uniformly. So can a patient have a seizure and be awake? And the answer is yes. However, when a patient is conscious and having a seizure, they won't always be able to tell you, yes, I'm having a seizure, and it started 2 minutes ago. They will have the seizure, be awake, and maybe staring off in space. It'll kind of look like I do when, Casey gives me my 50 kg in 2 minutes. Yep, that's your job. Am I picking on you tonight? Yeah, right. So anyway, they can, how kids are in school sometimes can have absence seizures. Teacher will say they're staring off in space. And could it be that they're sick? Could it be? Yes. Could they have a fever? Yes. Could they just be staring because they're wanting to stare? Maybe. So sometimes seizures are focal too. Sometimes it's a jerking arm. It's a tick-like thing, and you're not sure. Sometimes it's blinking eyes. So it can present in different ways. It depends on where you are in the brain. Anywhere up here in the higher centers, if you're seizing, sometimes it's that blank out. Because remember, I told you this is where we're actively thinking right now. So when you're listening, you're thinking right here. This is the part of your brain that's activating. So if you're having a seizure here, you're going to be out. So lights are on, but no one's home.
188 land retreat for the legislature against 188 land retreat.
Call back and tell them to get up off the floor. Yeah, might be. There you go. You guys can catch up because this is being recorded, right? Yeah. Okay. Thanks for coming. I appreciate it. To come to this, I'm when you're not here yet. Okay. So different seizure. I'm not going to hammer out the different types. Next slide, Tom. But we'll go through them just for information today. So some seizures are confusing because they can be confused with drug use or alcohol. And do alcoholics have seizures? You can bet on it. Some alcoholics will have seizures when they are intoxicated because of the alcohol in their system affecting the brain. Some patients, and more commonly, alcoholics will have seizures when they are withdrawing. Alcohol seizures, withdrawal seizures are a very serious thing. They are treated hands down with benzodiazepines, because that's how we treat alcohol withdrawal. So your good old Versed or midazolam is your choice. Okay. So let's go through a few of these. Consciousness is, and everybody knows this, it's a state of awareness. Lord willing, we're all conscious and alert right now. Dan, if you only knew, I was sleeping through the lecture. Yeah. So any decrease in this alertness is altered mental status. So we don't call it unconscious all the time, right? Truly, I think in the generic sense, we all say unconscious, and all of us think, the patient is totally out of it. Now, a lot of us will call in and they'll say, hey, well, this is, whoever, and they'll say, Doc, I'm bringing you a 23-year-old altered mental status patient. So that puts a picture in my mind of a patient who's a little confused or saying the same thing over and over again. Same call. Yeah. So it gives me a different picture. But if you called in and say, I got a 23-year-old male here who's unconscious, that to me tells me they're lying. So in clinical practice, we tend to use those two terms for two different things. Yeah, this looks like some of our. So when a patient is altered, that means something is affecting the reticular activating system, or the RAS. Remember that one slide I showed you just above the brainstem? That's where the RAS is. Right now, it's firing and working rather well because it's keeping us wide awake. At nighttime, when we go to sleep, the stages of sleep affect the reticular activating system and keep you from waking up. And when you go into REM, or rapid eye movement, that's your deep dream sleep. On the average, we're supposed to have REM of about 90 minutes during a sleep cycle. That's another lecture for another day. So our arousal is altered. So there's two ways. I thought this slide was really great. That's one of the reasons I picked this whole slide set. I thought it was very good. Two A's in consciousness. So you and I are communicating the same way. Are they alert? And are they aware of their surroundings? Okay. So I may be awake and my eyes wide open. The lights are on, but Dan's not home. Okay. Well, Dan, that's you every day. Okay. All right. I'll take now. But lights are on, no one's home. That's kind of that day's outlook. Sometimes patients are not arousable. That's a deeper level of unconsciousness. So you can wake Mary up. She's looking at you, but she's just staring. She's not aware. You ask her, what day is it? What's your address? Where do you live? Do you know where you are right now? What's going on? Totally clueless. And everybody in the room's got a patient like that, right? So those are your two big A's. Seizures that are recurrent is technically defined as epilepsy. Some family members, patients will tell you, I have epilepsy. Technically, what that means is you have had more than one seizure and you're being treated for a seizure disorder. The word epilepsy is an old term. It comes from the Greek. Epi means the beginning of or the top of, and leptic means jerking motion. So that's how it does derivation. So what causes epilepsy? Many times patients will have seizures of unknown origin. The most common reason for a seizure is reasons we can't define. The most common reason for syncope are reasons that we can't find. Isn't that cool? It's kind of frustrating because the poor patient is having seizure after seizure or syncopal episode after syncopal episode, and they can't find why. Happens a lot. But the focal sites that we do know of, there can be irritation in the brain. This is why we do a CAT scan on a random seizure patient, because we're looking for blood, we're looking for old stroke, we're looking for the brain has a lot of dementia. Patients that are older in their 80s and 90s will often have microvascular changes in the brain that will render their brain a little bit more prone to a seizure. Is it very common for an older patient, 80s and 90s, to have a first-time seizure? Not very common. Most of the time, seizures in that age group are pathophysiology from outside the brain. Electrolyte disturbance, cardiac abnormalities, or if it's in the brain, it can be a tumor or stroke. Okay, next slide. Back in 1981, and believe it or not, it really hasn't changed a whole lot since that time. We classify seizures in all kinds of ways, between generalized and partial as the two big groups. I looked up the most modern or up-to-date stuff, just to make sure our definitions are on the same line. Okay, thanks, Tom. So, based on whether the patient is awake or not, and whether it's one hemisphere or both hemispheres, is how they're defined. Dan, how am I going to know this in the field? It's very difficult. Most of the time, all you guys need to do is just tell me it's a seizure, and you can describe it. Is it generalized? All of us in the room know what a generalized seizure looks like, or tonic-clonic. Those two terms are synonymous. So if someone, just generalized seizure and their alertness and their awareness is gone, that's a generalized seizure, right? If they're one-sided and just doing on the right side, and they've got that lateral grace, that's a focal seizure. Could that be a brain bleed? Yeah, it certainly could, especially that lateral gaze. So that's how they're divided up. Simple seizures don't change your mental status. So simple seizure would be the absence seizure in the child, eye twitching, or maybe a little twitching of the lip or upper neck or jaw, trismus, with the jaw just clamping down. So those are simple. Complex seizures are a little bit more widespread because they involve more of the brain. And that's how they're defined. Yep, next slide. So that's just more of the same. Yeah, and what happens with focal seizures versus generalized? Is the treatment of a focal seizure different than a generalized seizure in the field? You're not. Nope. That's nice to know, isn't it? So you can walk out of the room and say, I don't need to know all that. And if you want to poo-poo it, that's up to you. But so I think, once again, I don't want to sound redundant, but I think the more you know, the more fun your job can be, because you can sort all this out. And when you hear providers talking and they say generalized or focal, or they had a partial complex seizure, now you'll know what it means. Okay? And there are seizures of what we call undefined undefined seizures, which means we just can't classify. Okay. Generalized is everywhere, and when we use terminology, we use this tonic-clonic, which is, believe it or not, some patients can have just individual symptoms along this line. Tonic means that their muscle tone is either flat, they're just flaccid, or their muscle tone is just like this. One of the classic tonic things that we never like to see is the brain injured or the brain almost dead patient with, disturbed or decortical posturing, they can be like that. That's tonic. Clonic is very similar. It's where you have clonus, and that's kind of a jerking, and it's more distal, so it's often the hands or the feet. Myoclonic we talked about earlier, that myoclonic jerking, and atonic is just totally flaccid. Okay? Tonic just refers to the tone of the muscle. Yeah, this is the big one and the most common. All of us in the room have seen that. This slide, I should have kept my mouth shut because this slide explains everything. Okay. Yeah, that rapid, the clonus. I don't know if you've ever seen clonus or clonus before, but it's an interesting thing. Some patients, a spinal cord injury. If a patient has a transection of L2-3, maybe from trauma, and they don't have any feeling down below, their reflexes may reflect that. Depends on where in the cord there's damage. And that's another lecture for another day, where in the spinal cord you have temperature, sensation, motor movement, and so forth. But anyway, when that happens, the reflexes can be abnormal, and one of the abnormal reflexes is a clonic feature of the feet. So when you take your finger and you rub up the foot like that, the foot will jerk back, or you'll see the foot jerking like this. That's called clonus, a clonus of the foot. And they may be hyperreflexive too. Okay? Yeah, this is important to know. The most important thing on this slide is this last sentence. You get called to a scene of grandma on the floor, or lift assist like this one. Can this patient have had that's for grandma. Could this patient have had a seizure and fallen on the floor? Yep, very possible. Okay, so seizures cause falls. We go through some slides that have some definition. I think we could go through these fairly quick. Talk about. This is important too. When we respond to a patient who says and tells us that they're having a seizure, or their eyes are fluttering, and when you try to move them, or you slap their forehead, or you take your fingers and try to squeeze between your fingers, and they suddenly wake up and stop seizing, that's probably what we used to call, or still call, a pseudo seizure or a psychic seizure. Now, some patients accept that as a diagnosis and they're okay with that. When they get very anxious or when they feel threatened, they will have a seizure. It's new call. Okay. It's just a way of them manifesting their anxiety. Everybody in the room has had a very stressful moment. So your stress may be a headache, stomach indigestion, diarrhea, abdominal cramp, and chest pain, shortness of breath, anger, frustration, withdrawal. So the pseudo-seizure patient, that's their cue. That's their physical manifestation of a mental breakdown or behavioral episode. Okay? Generalized seizures come in all kinds of forms, and the absence seizures in adolescence, if you get called to one of the schools for a child that has decreased responsiveness, staring off in space, that's one of the things to think about. Children often will manifest seizures in between the ages of 10 and 15, so something to think about. It's sudden. That's seizures come on like bang, bang, boom, and they are rapid in recovery. And I'll go over the difference between seizures and syncope in just a second. Okay. And that sounds good. Okay. Instead of absence, we have tonic-clonic, which is the other generalized seizure. Okay. This is you're all familiar with this. Arousal is out of it. And when they stop seizing, they may have a period of time where they're sleepy but they're arousable, or they're not talking right, or they're a little confused, or their speech is slurred, and then eventually they start to wake up. And sometimes you'll call in and you'll say, oh, this patient has a seizure. By the time we got there, they're post-ictal, and they look kind of out of it, and we did this and such. You bring them in, and when you're rolling around the corner there by the nurse's station, boom, they're wide awake, looking around, and we all look at you like, yeah. Well, the reason is because they're post-ictal period though. Now, where did we get a name like post-ictal? Well, the pre-ictal phase is where the patients may know that they're getting a seizure. Not all seizure patients have an aura, but some do, and they'll feel out of it. They'll have a headache, a little visual disturbance. Then they have the ictus, and we don't use that term anymore. The ictus is seizure. Then after the seizure is over, they have the post-ictal period. Ictus is the old Greek word for seizure. Yeah. Leptic or ictus. Isn't that cool? So that's the terminology. Okay? Now, this has changed a little bit. That's why I looked this up to make sure we're up to date. It used to be not long ago that status epilepticus was defined as a seizure activity for greater than 30 minutes. I don't know about you, but if you see your patient and your loved one seizing for 30 minutes without doing anything, I think it's time to hang your hat up. So that's a long time. So neurologists came to their senses and they figured if a patient is seizing for more than 5 minutes, or they have a seizure, they post-ictal, and then they go right back into a seizure again, and they get out of it, back into a seizure again. Those two scenarios are status. Now, how do we treat status? We treat it very similarly to a seizure, and they're done, right? We give them the benzodiazepines, and do we keep repeating the benzos if they still have a seizure? And the answer is yes, right. What do seizures do to the brain? It can eventually cause necrosis because they're not getting oxygen or perfusion, right? So keep that in mind. You're actually saving brain tissue with the use of benzodiazepines, much like you would be saving brain tissue to correct the dysrhythmias or to reverse a stroke. Okay, next slide. So this is the tradition, but this is the current practice. There you go. Next slide, please. This is a slide that explains what a partial seizure is. So partial seizures is just an area of the brain that affects a special thing. Their speech is off, they're hallucinating, they're seeing things on the wall, they have double vision, all of a sudden they see halos and then they don't. They have a headache. So doesn't that open up a differential, right? Headache with halos, that could be a migraine, or that could be an intracranial bleed. How about that speech slurring? Could that be a stroke? Sure could. So do we know if this stroke patient is a seizure, or do we know if the seizure patient is a stroke? It wasn't a seizure? You guys? Yeah?
It might have been.
Good job. Another one saying that's great. Okay. Hey, don't forget, you guys, that one of the things when we get called to a patient that's dizzy, one of the things of dizziness is a seizure, believe me. Next slide. So I think I already talked about this too. This is a little bit weirder too. Complex seizures are generally bihemispheric, and they can cause all kinds of symptoms too. Bottom line, to summarize all this, seizures come in different colors, and it can be everything from lights are on but no one's home to a full-blown tonic-clonic activity and everything in between. So if you see something that I like to call neural weirdness, now that's not a medical term, right? But if you see neural weirdness, this just doesn't make sense. This patient's off. Their speech is weird, their gaze is off, their pupils aren't right, they've got weird reflexes, something in the nervous system isn't right. See how simple that is? That's all you need to know. And you guys can assess the nervous system in a matter of a couple minutes, right? Because scene time is important, and you guys have to do a lot of information in this amount of time. And I admire you for that. I've got a little more time, and I've got deeper resources. Lucky me. But for you guys, it's like window of opportunity. And so it's like you're trying to fire your rifle at a deer that's maybe like 500 yards away, and you don't have a scope on your gun. So it's like, good luck. Yeah. As you can tell, I come from a family of a lot of hunters. So the post-ictal period can be sustained. It can be 2 minutes. It can be 2 hours. It's very rare that it goes over 12 hours. If it does, we've got another problem on it. Okay? This is a period of time where the brain is exhausted and it needs to regenerate. Remember what I told you? Energy stores are depleted, so it's got to build that ATP back up. So the mitochondria have to get really busy and manufacture a lot of ATP for energy. Next slide. Okay. Burnout. Now, burnout means you've been in your career too long and you got to go. This is a different definition. Burnout is where the patient physically and biologically is exhausted and they need some nutrition and fluids. Okay. So your patient's unresponsive, you don't see much physical activity. That's when you need to look and make sure that their eyes aren't fluttering. Open their eyes and see if they have nystagmus, either horizontal or vertical, because that could indicate that we still have seizures. Okay, next slide. Is it still a seizure or not? If you see anything that even makes you think that they're twitching or they're still ictal or still seizing, by all means, give them midazolam. What's the worst thing that's going to happen when you give them a benzodiazepine? Yeah, stop breathing. Can we handle a patient that stops breathing? We're all trained to do that, right? Can you get them through that time with the BVM? Yes, you can. Will they start breathing again? Yep, once the drug wears off. What's the half-life of midazolam? Anybody know? Yeah, it can last a while. But the immediate effects of midazolam can often taper off in about 40 minutes to an hour in some patients. So we get lucky in that regard. Okay? So this is more for us than for you, but we need to start thinking, is this a biological process that we can reverse? Hyponatremia, stroke, trauma. Okay, next slide. Okay, so ABC, as I said before, self-explanatory. Next slide. I don't want to keep it too long. Okay. This is obvious. This is first aid. So this is basic. This is anything even you can train and teach your bystanders. If any of you get asked to teach, a grade school class or go to the senior center and talk to the seniors about what to do when their loved one's having a seizure, do I take their glasses off? Yeah. How about removing the dentures? I don't know about you, but if they're clamping down, it's going to be impossible. If their mouth is moving, I wouldn't suggest sticking a finger in there. You'll get clamped on. If you can, it's probably not a bad idea to remove debris and dentures from the mouth because it can choke them. And always, why do we do this, you guys? Yes, right. Patients who are having seizure, and as you know, as general rule of thumb, any patients with altered mental status can vomit. And where do they like to vomit? In the back of the anus. Always. Yeah. So it's painful cleaning up the anus. So this is what you do. You make sure the scene is safe. You make sure the patient is safe. You make sure you are safe, because you don't want to be hit by the flailing arm. Is it okay to restrain these patients? Absolutely, because you're doing it for patient safety. Is it a violation of their rights? Absolutely not, because it's part of treating the immediate emergency. Suction and oxygenate goes without question, and you all know why. Check what you right? Hypoglycemia, glucose and oxygen, two of the most important things that they need. Does anyone administer thiamine anymore?
I think it's, I don't think we carried it.
Yeah, it's been off EMS formulary for a while now. It's fallen by the wayside, but still mentioned. Even in our setting, we don't give thiamine too often as just a general, let's give it because this patient could be an alcoholic. The reason for that is because it was not found to be effective. Why do we give thiamine? Because patients with alcohol abuse history and malnourished patients can be deficient in that B vitamin. And if we're replenishing the B vitamin, it helps them replenish nutrition. Is it critical in the EMS setting? It was proven not to be, and that's why it's off the phone. We rarely use it in emergency. So when the patient starts to wake up, what's the last thing you want to do is, scream, yell, lights on, all that stuff. You want to be aware that when they start waking up out of the seizure, they're going to be very frightened. They're not going to know what happened, where they are. So you want to gently remind them, my name is Dr. Wilson. You're in the emergency room at Haywood. You had a seizure. The ambulance brought you in, and you're going to be fine. So this is what you do. This is what we do. If their sugar is 35, right, we give them dextrose and then we check it. This is a big one. I haven't touched on that one yet. Can opiates cause seizure? Yes, they can. Why? Is it the fentanyl that's doing the seizing? No. The fentanyl causes decreased respiratory drive. Decreased respiratory drive causes hypoxia. Hypoxia causes seizure. See how it works? Right. So that's that. Now, this is an older slide. We don't use diazepam first line all the time, and I'll tell you why in just a second. And you always get ready for further seizures. When in medicine we respond to an emergency, always prepare for the worst. Never sit on your laurels after the initial treatment. Sit back and say, we're done here, we're ready for transport. During transport, what do you want to do? Be ready. Is that patient going to get sick again? Yep. Are they going to go into that dysrhythmia again? Maybe. So always be ready. Don't sit in your laurels. I'm preaching to me too. Next slide. So this is how we approach a complex seizure. It's all and that this all goes without saying. Next slide. I think we get down to the drugstore soon. Yeah, never seen your seizures end. Dan, what do I look for? The twitching eyes, the twitching fingers. Look for subtle changes or you bite them down in your jaw so hard they can't. That's called trismus. Next slide. Is that all?
That's all of it.
There was a drug slide on that. All right. Well, here you go. What do I do to treat this? Drug of choice in the ambulance that we use most often for seizures is Versed, or midazolam is the generic name. We generally start with anywhere from 2 milligrams up. Can I repeat that dose? Absolutely. I think protocol calls for 2 milligrams without calling, right?
For which?
For midazolam for seizures.
2 to 4, I think.
Yeah, I think it's 2 to 4, and then it's Medcon after that. Yeah. So, Dan, do I repeat the midazolam if they're still seizing? Yes. If they're status, yes. Can I use something else if the midazolam doesn't work? Yes. If you carry Ativan or lorazepam, yes, you can. Why? Dan, it's another benzodiazepine. Shouldn't it be similar? It is chemically. It is very similar, but it acts on different receptors in a different way chemically. Hard to grade and understanding for me to go through. But both midazolam and lorazepam are hydrophilic. What that means in English is that they are water soluble. So they get out of the body fairly quick. Whereas Valium or diazepam is lipophilic. It likes to get into the fat cells. That is why Valium is a longer acting drug. It's in your system much longer. And that is why Valium takes a little longer to work. And that's why Valium for kids that have seizures is given rectally, because it gets absorbed to the mucous membrane very quickly, much quicker than stomach, because stomach digests it first, then it has to go through first pass kinetics through the liver, and guess what the liver's full of? Fat cells. So bingo, Valium kind of hangs out for a while. So that's why we don't use it very often. So, if you guys don't mind, last thing on seizures, and then if you guys will take a 10-minute break and come back. The difference between seizures and syncope, right? Seizures often, but not always, have a prodrome of some sort or an aura. And seizures often will come on without warning. Boom, down you go, and you're shaking. Okay? So if the family member or the witness or the patients themselves afterwards can tell you, I knew this was coming, you can bet it was a seizure. Usually syncope has a process that gets there. Oh, I'm feeling very lightheaded. man, all these palpitations. I'm super dizzy. We've all seen those patients. And as this progresses, boy, I'm feeling really lightheaded and down they go. That's syncope, okay? Not necessary seizures. Number two, seizures often, and the most common seizures are the tonic-clonic, the jerking and the general motion. Syncope does not cause jerking like that. Syncope is often atonic, where the patients are just flaccid. And they may have some brief clonic movements, a little jerking, and all of us have had family members tell us, oh, I think they had a seizure. What went on? Well, grandma was feeling very dizzy in church, and we didn't have breakfast, and when they asked us to stand up for the final hymn, grandma just passed out. And when she was lying on the floor, she was jerking. Yes. And as a smart EMT and paramedic, I'm telling you that she was jerking because her muscles were not getting oxygen at the moment, and she was myoclonic, and that's just part of being syncopized. And she probably didn't breathe very well. It doesn't rule out a seizure completely, but it's a good clue. Number three, seizures often will have a prolonged post-ictal period. Once the jerking is done, they're out of it for a while. The syncope patient, on the other hand, once they're done with their faint, they wake up and, oh, what happened? And they're wide awake, they're talking to you, their speech is clear. So it's down and up. Syncope is down and up. Seizures are down and then maybe getting up. So it takes a little time. All right? Any questions that I help clear that up? There we are in a nutshell. You have just learned everything you need to know about seizures. Any questions? I hope I didn't bore you. Anybody in video land out there? Question? Okay. How about I've got 10 after. Is that right? You want to regroup at 20 after then? And potty break and
These are the, yes. Upside down.
yeah, this one was a 2.5 one, right? The 2.5.
Yeah, the T5 ones are working out fine. So everybody knows there were 2 rosters, 1 for each hour, right? So everybody signed the one for the first hour.
Everybody signed the first hour and some signed the second hour, but not all.
All right, not everybody apparently signed the second hour. And then okay, Chris.
Yeah, that's up to them.
It's that simple.
Very well.
Pay attention. All right, so we gotta shut this off so we can go into that one.
Yep.
Stop recording.
He's just signing off on it.
Again, stop recording this.